to please stay on mute. So I can tell there's some background feedback now, so please double check to make sure you're on mute. Thank you. I also want to ask that you hold your questions until the end of each section, and then we'll utilize the raise your hand feature, and we'll call on you. So just a recap of what we're going to do today. So we're going to talk about the 20th Century Cures Act and include some in-depth information on some impacts this will have to the teen proxy workflows as it relates to the patient portal. So the way the hour is going to go is I'm going to start with a little overview of the Cures Act. Then we're going to switch to Lynn Combs. She is our network manager of compliance and privacy. She's going to speak about the adolescent confidentiality law. Then we're going to move over to Stan and Anna, who are going to talk about teen proxy overview, some key considerations. Anna's going to talk a little bit more about the details of the proxy relationship in EPIC, what exists now and what's coming. And then we're going to have time for some question and answers. The people that will be participating will be myself and Lynn and Anna and Stan, as well as Logan Haig, one of our psychologists, and Keith Robinson, Vice Chair of the Department of Pediatrics. And I anticipate those on the panel will be joining in and participating in any questions that are asked throughout the presentation. So with that, let me share my slides and get started. Can everyone see my slides? Everyone except me, they just went away. There they are. Okay.
Yes.
You still see them. Okay. So we're talking about the Cures Act today. And so I want to start on my first slide instead of my last. There we go. So I assume most of you know what it is. There have been some communications sent out. There was also discussion about this last fall because the initial implementation of this federal rule was to be in October, but it was extended till April 5th. So basically, on both inpatient and outpatient, as well as all lab, radiology, and pathology reports to the patient portal. There are some specific exceptions to the mandatory release, with the most clinically applicable being the release. Can I just ask that everyone just double check and make sure you're muted? I'm getting quite a lot of feedback here. So there are some specific exceptions to the mandatory release, with the most clinically applicable being that the release could present physical harm to the patient. They do specifically call out that emotional distress is not an approved exception for releasing information electronically to patients. There are also exceptions that exist for privacy reasons. For instance, the note contains information about a third party or a person that would be a violation of their privacy if it was released. And there is also an exception if the patient requests that the note not be or result not be released. So let's take a step back and see what actually do patients want. So there have been a few studies, they've been small, that have been published on this. And in the studies that are published, 70 to 80% of patients say they want their results immediately, even if it contains a new diagnosis of a serious illness. According to an EPIC listserv, many institutions are releasing most labs immediately. Geisinger is, Stanford has said they are. And when they are asked why, they say they acknowledge that most patients want them. So this doesn't include all patients. So what about the patients who don't want their results? Well, patients who don't want the result released can request that the result not be sent to the portal. And they even have the option to turn off the notification email they get when a new result is sent if they don't want to know when it's done. So what does this mean for the way we deliver medical care? Well, I think it's going to result in some slight variations at the time we order tests or procedures and deliver care. So providers really are going to need to educate patients at the time a test or procedure is ordered about the possible results they could see and the choices they have for obtaining the results, so that it's not a passive choice, but it's an active choice. If they want to know immediately, the results will be available in the portal. They can wait for the provider to contact them, or they could even arrange to come in for a visit if they want to get the results that way. But instead of just having it happen passively, it's important that it's an active choice. And what are we doing to help patients? This is different. This is a change for patients as well as providers. So here's some of the things that we have done and are doing. All MyChart users will receive an email reviewing the changes that they'll notice with the Cures Act. I believe that email is supposed to go out this coming Monday. The after visit summary in the MyChart portal will be updated to inform patients of the immediate availability of most results and notes. The email notification that's sent with new results will remind patients they are getting their results immediately and likely before the provider has seen them, and to please allow 2 business days for your provider to follow up with you. So in summary, this federal act, we can make this a positive addition to our excellent patient-centered care that we already provide. It is going to require some adjustments in the way we deliver care, as well as helping patients set expectations for receiving their results. We know that many patients want access to their results immediately, and I'm asking you to please review the communication that was sent out last week for specific details on EPIC changes related to releasing results and notes. I'd also like to remind non-UVM MC sites will be providing updates regarding their legacy systems. So that's an overview of what's coming, a little bit around the why and some of the things that we're going to need to change. And with that, I'm going to transition over to Lynn Combs, unless anybody has an immediate question about anything I just said.
Thank you so much, Ray. My name is Lynn Combs. I'm the Network Manager of Compliance and Privacy. As Ray mentioned, I'm going to go through a little bit of the legal basis for our presentation today, which is talking about what adolescent patients can consent to on their own, meaning that they also have a right to privacy to that information, and how we're handling that in terms of MyChart and proxy access. So let me start my slides. Can everyone see my slides? Okay.
Yeah.
Excellent. Thank you. So as you all know, the general rule when we're dealing with patients who are under the age of 18 is that they are not able to legally consent to medical treatment on their own. They need to have their parent or guardian consent for them. As a result to the general rule in terms of consent is if you are able to give informed consent, then you're also entitled to confidentiality for that treatment that you consented to. So confidentiality and the ability to kind of control your medical information is generally tied to what you are legally allowed to give consent to in terms of treatment. When it comes to minors, there are a number of restrictions, or I guess exceptions is a better word, about things that minors can actually consent to without their parents' involvement or guardians' involvement. I will say most of these laws are specifically Vermont laws that I am mentioning, but I will say that New York law generally mirrors these same kinds of restrictions, and I have a slide at the end, but the concepts are basically the same. So if you have questions specific to New York law, you're welcome to reach out to our office. Under Vermont law, parental consent is not required for emergency treatment for a minor that's needed to save the minor's life or the minor's health. This is true in all cases of emergencies, not just for minors. Minors of any age may consent to outpatient mental health treatment as long as that treatment does not include the use of and prescription of prescription drugs. So that would be the one carve out in the outpatient mental health treatment world. Minors of any age may also consent to treatment for rape, incest, or sexual abuse. And also, minors of any age can consent to treatment for pregnancy, contraception, and abortion, as long as the provider deems that the minor understands the purpose of the treatment, its risks, benefits, and alternatives, and is capable of making an informed decision. So basically, as long as the provider determines that the minor has capacity to give informed consent in that situation, then they can do so without parental consent or needing to discuss with the parents. There are also some exceptions under Vermont law that are specific to adolescents. In Vermont, adolescents are defined as being minors between the ages of 12 and 17. One note, and I do have this on a slide coming up, is that under New York law, minors are generally defined as ages 10 to 17. So that is one important caveat to note. Some of the things that adolescents can consent to are treatment for outpatient and non-medical inpatient substance use disorders, so drug and alcohol treatment. I will note that there is a specific Vermont law that says that if the treatment requires medical hospitalization, so that's treatment for substance use disorders, and as you'll see below, also for sexually transmitted diseases, if it requires hospitalization, the provider is required to notify the parents. And minors, again, between the ages of 12 and 17 can also consent to treatment for sexually transmitted diseases, but if hospitalization is required, the providers must notify parents. As I noticed, as I mentioned, New York law generally mirrors the Vermont privacy laws on these issues. In most instances, though, New York law does define adolescents as minors aged 10 to 17. So that's a little bit of a distinction. If you do have specific questions about New York law, you're welcome to contact the Network Compliance Office, which is myself and Jennifer Parks. And then we also have a New York Regional Privacy Officer, Lindy Gunderson, who you're also welcome to contact. She's the dedicated privacy officer for the New York region. Some other exceptions to note to rules about not being able to consent unless you're 18. Minors who are 14 and older may consent to voluntary inpatient mental health treatment, though that consent must be in writing. Again, to note, if the treatment requires hospitalization, so medical hospitalization for substance use disorder, the provider is required to notify parents. Emancipated minors are able to give legal consent. They're considered adults under the law. And then also minors who are on active duty with the military are considered adults under the law. So that's kind of the groundwork that we've been operating under in terms of how we've been addressing the minor proxy issue, and particularly proxies for adolescents, and allowing their parents to access information in the patient's MyChart account. I'm going to turn it over to Stan and Anna to talk a little bit more about what we are actually doing and what we've already done in terms of setting up Epic and MyChart. But one thing I will just note before I turn it over, with respect to minor privacy issues and privacy issues in general, it's also important to always be mindful of our reporting obligations. So for example, if we suspect child abuse, or if we discover that a minor under the age of 16 was a victim of a violent crime, we do have obligations to report. And then of course, this is also subject to our duty to warn obligations if we are concerned about a patient presenting an imminent threat of harm to others. And I will note, I do have my contact info and I can share these slides on here, but I also included Jan Ferguson and Erica Smart, who are our experts in concepts of consent. And then also with respect to duty to warn issues, Erica is my go-to expert on that. So with that, I will turn it over to Anna and Stan.
Thanks so much, Lynn. I'm Anna Hankins. I'm a pediatrician in Central Vermont and the medical director of pediatric primary care here at CVMC. The Cures Act is a huge change for physicians and providers, because up until now, we have really owned the chart and decided when to dole out pieces of it. And there was always this vague idea that somebody could go to HIM and request that their chart be printed out for them. And we always thought that was a little bit weird, and they never really did it anyway. And so we never had to worry too much about it. I always thought I was pretty avant-garde for encouraging my parents of young children to sign up for my chart so they could see my notes, but I would never have thought about doing that for adolescents, because I don't want the parents of my adolescent patients to read my notes or really have access to that information, because so much of what we put in our notes is confidential and related to those confidential discussions that we have with adolescents. And so this becomes really complicated now, because we are now, rather than tightly holding on to the chart and deciding when to dole it out, we're legally obligated to share that information immediately and not to block any information unless it is to protect an adolescent's confidentiality. And so we've been having a lot of meetings with pediatric and mental health providers, information technology, and lawyers to try to figure out how all this works. And it's actually been interesting watching the progression of those meetings, because they were just a little cantankerous in the beginning. I remember thinking, how can Lynn possibly tell me that I have to share some of this information? And so we had to figure it out as we went along. So we had to figure out how to allow parents to have access to the information in an adolescent's chart while not allowing them to have access to the information that is confidential. And we were limited in this by our electronic health record, which has certain capabilities and doesn't have certain capabilities. So, it would be great if Epic knew that it could share with a teen's parent that the teen is on clindamycin for their acne, but not share with the parent that the patient is on clindamycin to treat their STD. Or that it would know that it could share that they had an appointment with a foot doctor, but not that they had an appointment for an Nexplanon placement. So it's not that smart of a system. It'll probably get there at some point, but for right now, we have to work with it as it is. And the way we've set things up is that when an adolescent turns 12, if their parent already had access to my chart through what we call the proxy, it will roll right over into a new limited proxy, where the parent will not be able to read notes because they might learn confidential things, won't be able to see medications because they might learn that their adolescent is on birth control or something like that they're not allowed to know about. And so it becomes this very limited proxy. However, we recognize that in some situations, the parent really needs full access and needs to be able to see everything that's going on. So think about a very cognitively impaired adolescent, or a 12-year-old who is just going through really complicated medical issues, and the parent needs to be able to get in there, see the med lists, read the notes, and really be taking a hugely active role. So we have a limited proxy and we have a full proxy. The way it gets decided is the teen gets to decide, and the teen gets to sign the form that says, yep, give my parents the full proxy. And then as medical providers, we need to be really aware of what that proxy status is and be having an ongoing conversation with our teenage patients about when they would like to revoke that proxy access. So the parent has proxy access, the teen gets to decide when to revoke it. We need to be very aware of it and be gently coaching the parent and the teen through this and really making our own recommendations. So our 12-year-old may sign the form saying, yep, full access, whatever, mom. And then when that 12-year-old comes back for their 15-year-old well check, we need to know how to find that setting in Epic, see, oh my, your parent has full proxy access. We need to have that conversation with the teen. Is it really appropriate, et cetera? And then when the teen says, no, I really don't want them to have full access, I want them to have limited access, as the provider, we can make that change in Epic. And we need to be comfortable knowing how to do that. And I'm going to be quiet and let Stan take over for some time, and then I'll jump back in just to talk about the nuts and bolts of finding that setting in Epic and those sorts of things.
Sure, thanks, Anna. And I'm Stan Weinberger. I'm a pediatrician up here at the UVM Children's Hospital Pediatric Primary Care Practice, and I'm the division chief for pediatric primary care up there. And yeah, Anna, you touched on a ton of important things and in considerations, right? You know, we do start from the place that it's really important for families and patients to be engaged in their care. In general, that is a really good thing. And in particular, our adolescents, we want to be engaged in care, right? And we also respect this clinician-patient, clinician-adolescent privacy rules. And those are in place for very important things. I know Lynn kind of pointed out what the rules are, but those are there, those laws and those practices are there really to protect the health of individual patients. You know, we know that teens will not seek care if they don't feel if they don't feel comfortable with that, if they feel like that information, if it was disclosed, would cause harm to them, and it also protects the public health in that way. And in general, you know, this does help adolescents grow in their ability to engage independently with the healthcare system. So that's important. We also know, right, that adolescence is this time of great change. Anna, you pointed out, I mean, the 12-year-old who consents to full proxy access is totally different than the 16 to 17-year-old who might have some totally different confidentiality needs. And prior to my chart and the Cures Act, right, we dealt with this all the time in our office because we routinely have parents step outside of the room to discuss confidential matters. And that's an ongoing conversation, you know, that we have both with teens and parents, so they understand, you know, their rights. They understand what it means to, you know, take away that access or what giving full access might disclose, and how to manage that as they grow and develop in maturity. You know, the other principle that's helpful too is that, you know, in general, adolescents do best when they have a supportive family around them. It's really hard to carry around confidential information that you don't feel comfortable sharing, you know, and so as pediatricians and family medicine docs and other folks who interact with adolescents, you know, we long, even though we strongly protect confidentiality, you know, we work to help teens with that information and help them disclose that to their families in a safe way when that's possible. Understanding that, you know, that really, when that can be done in a safe way and with the teen's consent, that can be really important for their health. So I think it is important for us to kind of take those considerations and realize that we have been doing this through a lot of conversations all along in the office setting, and now we need to move this to the electronic setting with MyChart, which will be different, but is important. And I think an overarching message of that will come through in the materials, and I think I would like us to put forth to our patients and our adolescents are that, you know, when you have a question about confidentiality or about information around my chart and how to sort out what's best for you as an adolescent or you as a family, the most important place to turn to is your medical home. You know, that the doctors or specialists that you know the best that you know, can help walk you through these sometimes challenging but really important conversations. That's our job. And my hope is as we get used to cures and this information that we, you know, one, as Anna said, know how to find the proxy class, so at least we can understand and talk to the adolescent about what they have and what that might mean for them. Know how to help them protect that and how to document that so that we're following the Cures Act and the confidentiality laws, but that we become increasingly comfortable in having these conversations and discussing these issues with families, right? Not just as we had done in the past when we would have the parents step out of the room, but now in this electronic domain. And did that trigger any more thoughts from you?
That was great, Stan. Well, so let's talk straight nuts and bolts, because we're not going to be able to have these complex and sometimes challenging conversations with our families if we're distracted by going, I don't know what the heck a proxy is, and this is all confusing to me. So we all have to have it straight in our brains. The way I think about it is that for grown-ups, it's pretty easy, partly because I never think about grown-ups, but a grown-up just signs up for my chart. They can do it online, they can get an email, they can get their little access code on their AVS, easy peasy. A child, so 11 and under, if they're active on my chart, it's because their parents signed a proxy form. So at my clinic, it happens at checkout. The checkout person says, oh, I see that you're not active in my chart. Let me have you sign this form. And what that form does is it's saying that that parent is going to access their child's medical record as a proxy. And so the child isn't doing anything. They're you know, maybe a 3-year-old or a 4-year-old, it doesn't really matter, but the parent can log into my chart, read the notes, see the labs, see the meds, send the doctor or the clinician a message, full access. And then it's those pesky 12 to 17-year-olds where it gets complicated. So when all of this goes live in the first week of April, starting then, any kid who turns 12, that proxy access that their parent already had is going to automatically roll over into a limited proxy. And by limited, we mean it's really shut down to protect against anything that might violate the adolescent's confidentiality. And parents are going to notice if they use my chart all the time and they're used to being able to read notes and see the after visit summary and see the med list, they're going to notice and be like, whoa, why can I not see everything? And that's going to be an opportunity for a conversation about confidentiality. At that time, the team can choose to sign a form to switch the parent over to full proxy access, where it is wide open. They can see everything, they can read everything. And that might be very appropriate at age 12. I imagine that a lot of my patients, the mom is going to be like, here, sign here. And the kid's going to be like, okay, and sign, and is really going to have no concept. So that's 2 classes of proxy information that a parent could have. They could have the limited locked down, or they could have the full. There's also a 3rd class, which just is a little wrinkle. All the adolescents that currently have granted their parents proxy access. So right now in the whole network, there's about 1,200 patients who are adolescent and who have given their parents proxy access. They are sort of grandfathering into this new scenario, and they're keeping the proxy access that they already had. And it was sort of this sort of partially shut down proxy where the parent can't read notes, but they can see pretty much everything else. So rather than funneling all of those patients into one of the two new proxy classes, they're going to just stay with what they have, and eventually they'll all turn 18 and it'll be done, and we'll be left with our two, limited and full. But until they get older, there's going to be this third weird proxy. So you have the limited, you have the full, and you have this weird in the middle one. When you see a patient who's an adolescent, it'll be important to know. So you can you can look on your storyboard on the side pane of Epic and see a My Chart little icon that you can click on it. I'm not good enough at finding things in Epic to be starting to look for little symbols and finding them on storyboard. So whenever I need to find anything in Epic, I just type it into the search bar at the top right. So, you know, I don't know where health management is, but I can type health management into the search bar and then let Epic find it for me. And I can do the same with My Chart. So you can click on the icon, or you can type in the search bar for My Chart, and you want to get to My Chart administration. And there you're going to see whether there's just no active My Chart, and then you can have that conversation with the teen and the parent. I think we should sign you up for My Chart, and you all need to have this conversation about proxy access. Or you're going to see what kind of proxy access they have and comment on it and say, I see you're signed up for the full proxy access. That may be appropriate right now because Tommy is only 12 and you're really taking an active role in managing his, name that, chronic disease. And as Tommy gets older, we're going to need to talk about switching over to a more limited proxy access as he needs more ability to have confidential care and needs to take more responsibility for his own health care. And so the key is understanding the proxy classes and being able to find what the status is for each of your patients in the chart. The team needs to sign a form to sign the parent up for full proxy access, but the only thing you need to revoke that access is document in the medical record that you had a conversation with the teen. You all decide, the team consented to revoke the full proxy access, and then you just click the button. It's a one click and done to revoke it. So we don't have to have the team sign paperwork and do all sorts of hoops. We just say, yep, they told me, and we're turning it off. So with that, Stan, unless you have anything more to add, I think we should probably open this up to questions and discussion.
Sure. I have one other thing that came to mind as you were talking. Right. We talked about the limitations around Epic and how part of the reason we have these two classes of proxy, one that is very limited and shows, just allergies, immunizations, preventive health maintenance items, growth and weight charts, and COVID-19 tests. And the other that has everything is because Epic, has limited sophistication to figure out what exactly is confidential and what's not. However, there are different layers of protection that we can enact to help walk our teams through this. So there is the proxy access and revoking that full proxy access in concert with the teen. There is also the ability to withhold specific notes. And there's also the ability to withhold specific results, which you can do at the time of ordering. Again, those all need to be done within the rules of information blocking, right? Not because we're worried that it's going to make the teen or us uncomfortable, but because it really, you've had a conversation with the teen, and it's part of that confidential care, and they're requesting that, or because it may cause harm to the patient or some third party, and document that. but there are other layers that can be done. There is even a confidential encounter. And so we will work to get familiar with all of these as we go. But no one layer with our current EPIC sophistication can provide, that perfect separation of protection for an adolescent who is changing between 12 and 18.
So what questions do you have? We want to make sure we have enough time for discussion as you're mulling around thinking of your questions. I will tell you, so the technical how to deactivate proxies and change access will be sent around in a communication that's currently being reviewed. So you'll have clear directions on how to do that. One of the things you'll notice is we've tried to send out communications multiple times on this to try to keep giving you information. So please do keep reading it.
I would say we also have put together, and it's just being finalized, kind of a frequently asked questions, which looks at, we'll spell out, these are the two types of proxies. This is their official name. When you look in EPIC, that's exactly what you will see. And this is what the proxy will be able to see, and then some scenarios, right? Because I'm sure as you're thinking of questions, you're thinking of common scenarios in your head and with particular teens, right? And how am I going to handle this? And so that will be going out.
This is Marge. Can you clarify a little bit more about the issue of third-party data within notes and suppression of those?
Sure, I can at least lead off on that. This is Lynn Combs, and sorry, I'm trying to also respond to some of the questions that are coming up in the chat. So if I don't get to them, I'll respond afterwards. But yeah, so that would generally be something I would say falls under the privacy exception. So the privacy exception is basically when there's information in a note that would require an additional type of consent or additional person's consent beyond just having access to the note in general in the first place. So if you have like PHI about a third party in a note, that would be a basis to withhold the note. And then also I would say just, so I know we don't want to go into the mother and baby situation now because that's kind of a unique one, but it's a good example because oftentimes a newborn record will include a lot of information about the mother's history because of all the neonatal or the prenatal treatment is going to be the baby's health information. So like if there's information about the mother having hepatitis C, for example, that would go into the baby's chart, and that would be something that could be withheld on the basis of protecting the mother's privacy, that the father may not, or the other parent that has access to records may not know it. So that's a good example, I would say, although I've also talked with some mental health providers that have talked about situations where they are treating an adolescent and they have information about the other parent in there that might be used in a divorce situation, like other parent has an STD or other parent has a bunch of boyfriends, I don't know, something like that. And I think that would potentially also be something that could fall under the example of something that you could withhold to protect the privacy of a third party. Does that answer your question? Is that helpful?
Yeah, I just want, it's just, we've obviously had a lot of emails, and that it's just surprising to me. I'm hearing about this right now. I think it's great. It's exactly what we need. And we may have to withhold a lot of newborn notes. We can talk separately, but
Yeah.
I was under the impression that we couldn't do that. So I'm glad to hear that's not true.
Yeah, and I'll be honest, the newborn note issue is one that we've been going back and forth on, and it's a very tricky one that we've reached out, to others in the organization about and others in other organizations about. So I haven't had a chance to circle back with the team yet about a proposed workflow going forward. I think in the current time, I'm fine with somebody manually withholding a note for that basis if it has the mother's confidential information. I think obviously we need to be smart, beyond just the newborn visit about not withholding things, perpetually from the record as the child grows. And and always happy to consult on a particular issue, I would say too. But yeah, we can definitely circle back separately on the maternal record issue with newborns.
Yeah, and I can also just add to what Lynn said. We've had this discussion with a number of different providers on NICU attendings, and certainly that's been my answer when I've been asked. There's also been some discussion about the providers thinking maybe there's a separate place they're going to document this, so they won't have to, withhold the whole note. But really, it's up to you guys what works best for your workflow.
I'll just note something came up in the chat too about exceptions for mental health providers and emotional distress with notes. We kind of have had a separate, although there's a lot of overlap, we have a lot of our mental health providers who deal with PEDS patients here on the call. So we've had kind of a separate track going with some best practice recommendations from the Department of Psychiatry for how to deal with this open notes change with your patients. So I'm happy to circle back with that, and we can circulate it too. But I will say Andy Rosenfeld is kind of the Department of Psychiatry point person, an expert on this, although I will say Dr. Haig's on the phone, and there are a couple of others who have been working very closely with us as well.
I'm just noticing one other question that came up in the chat is asking if adolescents will have full access to their own notes, and realized that I wasn't clear when I was giving my description. So when an adolescent signs up for MyChart, let's say you have a 17-year-old in your office and they just sign up for MyChart, they can grant their parents limited proxy. They can grant their parents full proxy, and that status only affects what the parent can see when they log into MyChart, but the adolescent gets full access. This is their chart and they can read it.
The only caveat I would say to that is the adolescent doesn't have a choice about the limited proxy piece of it. If they set up MyPart, the parents are entitled to the limited proxy because that's, they are legally entitled to that information. But yeah, it is up to the teen. Sorry, Anna, didn't mean to jump in there, but it is up to the teen in terms of the full proxy status. That's kind of where we're at with this. And I saw a question in the chat about advising clinicians who are not primary care providers for adolescents how to provide sensitive care. So I think I will lead off with the spiel that I think part of what we want to do here is to help guide that. That's part of the purpose of this discussion about what to be aware of. So I'll leave it to Anna and Stan for some of the best practices. Although I will say, Anna and Stan, I don't know if you saw my email, but we're still trying to figure out that confidential encounter thing. So I don't know that that's formally a best practice yet, but I'll punt it to you guys to talk a little bit more about how people who aren't every day dealing with adolescents should approach this.
Stan, you want to jump in?
Sure, I can jump in. Yeah, I mean, I do think it's important to understand that, right? Any adolescent who signs up for MyChart will have full access to their own health record, including notes. And right, we when restricting notes so that an adolescent couldn't see their own notes, we have to be really clear about the reason for that. And we should be clear as we're writing our notes and talking to teens that, these are the things we're talking about. This is why, as we've been doing all along, these are, the diagnoses we're talking about, or the, the treatments we're talking about, because they will be able to see that. I think, for a non-primary care provider, it's important to think about, what types of care that I might be providing fall under these confidentiality rules, where a teen is entitled to confidentiality around sexual and reproductive health, mental health, substance use, and in particular, if I'm going to be, prescribing care or getting into those issues, to be able to have a conversation with the teen that, these are protected within certain exceptions, of harm to yourself or others or abuse, but these are protected, and who else Do you want to be able to see this? For example, your parent, either, we might talk about it in the office, or they might see it on my chart, and have a conversation with the teen about that. And that may be, a significant change, or it takes a while to get comfortable with that. If that's not, a normal part of your practice, right? Because for many specialists, those types of issues are not stuff that you're getting into on a daily basis. It is also helpful to bring the primary, I think most primary care providers welcome being brought into that, or saying, please follow up this conversation with your primary care provider, because that's what we do.
In my mind, any provider who is seeing an adolescent about something confidential, whether that be an OBGYN discussing Nexplanon, a psychologist initiating mental health counseling, or an urgent care clinician doing STI testing. That is the moment that conversation needs to happen. You've kicked the parent out. You're talking about something involving sex or mental health. You need to say, hey, let's check your MyChart proxy status. Did you know that your parent can read every note? Do you want them to be able to? No. Okay, let's turn it off. And then you can send a nice staff message to the PCP saying, FYI, I think that would be great. But the real worry I have is that a provider who doesn't see teenagers very often isn't going to have this in their head. The teenager may not have seen their PCP for a couple of years. They signed the full proxy because their mom told them to when they were 12. Now they're 15 and they're seeing GYN or urgent care. And if that's not in your brain to say, hey, let's check that proxy, I think it may be time to see if you wish to revoke the consent you signed when you were 12, then we're going to have confidential information flowing to parents.
I think all that's exactly right. I mean, I obviously am not going to disagree with our expert clinicians here, but I will just say, I think in my mind, visualizing the ideal workflow is it's probably something that would not be entirely turned off by a provider that doesn't have an ongoing relationship with the patient. And the clinician experts are going to chime in if I'm saying something wrong, but I would say, I really like the idea of turning it off and then sending a note to the primary care provider or something like that and just alerting them to it. There are other workflows. You can manually withhold records for that reason, also for a privacy reason, if it's something the kid wants kept private rather than turning off the full access. But I will, what has become clear to me in working with all of our pediatrics experts here is that it really is part of a larger ongoing conversation that they have with their patients as their patients grow and mature. And it's part of the progression of treatment, from the teen patient being there with a parent the entire time to being able to make their own decisions. So I would strongly encourage everyone to do it in partnership with the primary care provider, because it really is part of an ongoing or a much larger relationship and developmental relationship that the patient has.
So there's a question in the chat from Katie Naden asking about more clear descriptions of exceptions. And I think we can certainly send that out by email. I would point out, though, that we're having two different conversations here. One is, what are the exceptions for like a grown-up who's seeking care? When can you block information to that grown-up about their own care? And those are really very limited, and it really is physical harm or third-party privacy. With the adolescent, what we're talking about is not what are the exceptions to allow us to block the information to the patient. We're talking about how do we protect the adolescent's confidentiality while still recognizing that their parents have access to the rest of their chart. Their parents are supposed to have access to the all the information about their diabetes or their concussion or their whatever, but not about their outpatient mental health counseling and not about their reproductive health. And so when we talk about the explicit exceptions, we have to be really clear in our minds. Are we talking about adolescent confidentiality, or are we talking about when can we block information to a patient?
Yeah, and I think that's a good note. I will say from the technical perspective on that, everything that we're doing with this pediatric proxy build and the entirety of the discussion today is all basically under the privacy exception, because the law affords additional privacy to the adolescent patient in these situations, and we are not allowed to release their information to parents unless we have additional consent beyond just I'm the parent and I'm entitled to the record. So while privacy is a blanket exception that you can apply in any situation, a lot of what we're doing here and talking about today is all based under the exception umbrella.
Yeah, there was a question from Haley McGowan in child psychiatry around, an encounter in the emergency room for suicidal ideation where a note may include sensitive information that falls under those confidentiality protections that the teen does not want their parent to see, right? And so that would apply, and there would be some options. One would be, to talk with the teen to restrict the proxies full access, right? Or to withhold that note in document-wise. So you can withhold a single note.
And just to let everybody know what's coming, for those of you who have read some of the emails that you've received, when you withhold a note or a result, you actually get a pop-up and it lists these 3 reasons, and you just click which reason it is. There is a place for a comment if you want to put one in, but it's not required.
Sorry, this is radiology. Can I ask a question that might pertain also to other labs, not just imaging, but specifically, and Lynn, we kind of talked about this already. Let's say there's a placed order for let's say a young child, and an unexpected finding of specific finding for child abuse is found. And the privacy was not requested for that specific note. Radiologists do not have an options to block those. And when I talked to Lynn, we identified a workflow which would be difficult to follow because it's a little bit of a manual workflow, not to finalize that report before we actually talk to the primary provider. It's reaching the provider is always difficult, and not always difficult, sometimes difficult, I should say, rarely difficult, probably even is a better word. But it's also a workflow that I can see being forgotten about. So is there a way for radiologists or any labs for that matter, temporarily block or restrict access to that specific result?
So I can speak, I think, unless Ray wants to speak to this, he might be better positioned.
Go ahead, Lindy. The answer is yes. You have access in Epic to deactivate a portal, just like an ED doc would or a primary care doc.
Yeah, so I think my understanding from the Epic teams of the recommended workflow is that the radiologist who's doing the resulting or a pathologist who's doing the resulting or whomever can go into the order and change it to say withhold, and then the result would also withhold. And Ray's going to jump in if I'm misstating the Epic workflows here. But I think the other one is also that if it's absolutely necessary, particularly in an instance like with child abuse, you can potentially go in and temporarily turn off the proxy access, and I think any provider can do that. The important thing that we are requesting in all of this is making a note somewhere in the chart about why you're doing it. At the end of the day, all of this stuff we're going to have to explain later, and so other people know. And I think that's the biggest key is if you as a provider, as a resulting provider, are making a change or something like that, just make sure you're documenting in the note. And I think it's also important to send a message to the ordering provider, to the primary care physician, something like that, alerting them to the issue. And I'm getting a lot of nods from my team here, so I guess that means I'm on point. And you know, at least with the child abuse, I don't have in real life a sense of how often this is an issue. But my hope is that it's not super common, and you know that it's not something that's going to come up a lot. But I think that's all important. And also, I would say the other issue is with all of these questions, you know, in the same way that Jennifer Parks and I are always available to you all for questions about HIPAA or billing or anything else. If you have any questions about fact-specific scenarios, Jennifer and I can be paged through the PAS system. I check my email. Ray can attest to this. I'm on my email most of my awake hours. You know, people are welcome to give us a call if there's a fact-specific scenario that they're challenged with. We're happy to talk through it.
Yes, we are available to help in any way we can. And I see David Claus has his hand up.
Yeah, this actually just makes me think. So in the very infrequent situation where an emergency department visit, as an example, has a finding, whether that's a radiology finding that might be suggestive of abuse, as Jay had brought up, or a lab result or something, where we would want to withhold the note. And we do that, and we're sensitive to the issue when we do that. One of the problems in the system I see is potentially that the actual results don't automatically get blocked there, correct? Only the note that contained those results, but the results section would still be released. And I can see providers being caught up by thinking they had done the right thing, but not really blocking.
So I can speak specifically to the EPIC workflow. It gets a little bit more complicated when we move to the non-EPIC EHRs. But with the EPIC EHR, you know, if you're not withholding a particular encounter or something like that, you can block, you do have to block the note. And then you would also have to block when you place the order for the image result or whatever. If you block the order, the result coming back will also block as well. And you'll get a prompt, and I apologize, we don't have screenshots, but they are coming out in EPIC tip sheets. You'll get a prompt that asks you why you want to withhold something, and so that you can document it. But it is important to note that you would, if you're doing it at a note level, you would have to withhold both the note and then also the order / result that gets tied to the order.
Exactly.
There was a great question in chat about whether we should be no longer having the front desk initiating MyChart signups for adolescents because this is so complicated. And my answer, and Lynn, you're going to see how much you've taught me through the last few weeks of meetings, is that information is supposed to be going to the patient and to their proxy. And so we should be encouraging MyChart signups. The key is for the PCP and anyone else involved in confidential adolescent healthcare to be recognizing the current adolescent proxy and discussing it with the patient if it seems inappropriate for the care that they're receiving.
Agreed.
Yeah, I was going to say, Anna, you've taught me a lot too. We've definitely had a good learning experience for all involved here over the past couple of months, I would say.
Yes, and I would just like to say that I certainly appreciate everyone's time and attention to this. While we didn't come up with this rule, you know, we're doing everything we can to make this as a positive change for our patients, because that's what we do. And we remain at your disposal for questions, and we'll help with this in any way we can. So I think we've about reached the end of our time. I just want to thank again everybody for coming and for everybody who participated.
And we're always here, so I'm only an email away. You know, I think Stan and Anna and Keith and Logan have been really excited to dive into all of this information and are very excited to share their expertise with everyone going forward, right, guys?
And I know this session's being recorded. There was a lot of questions as well as answers kind of flying through the chat. And so presumably, hopefully we're saving that chat or some of that.
Yeah, I'll go back through and make sure we've answered all the questions, but if anyone wants to have an offline conversation, absolutely happy to engage in that further. And we will definitely separately circle back with the mother-baby experts and those departments about how to deal with the newborn note issue, which is a whole other layer of a sticky wicket.
And I believe there was a question I didn't get to it about legacy systems at Porter and how to deal with that. And that always starts with a question of how are you dealing with it now, and going from there. So happy to help in any way I can.
Yeah, and I can reach out separately. Ray, the Porter legacy systems, we have some awesome people at Porter we've been working with that can give you more specifics.
Okay, well, thank you, everyone.
Thank you, everybody.
Thanks,
I
all.
will just note one more thing before, everybody's leaving. Never mind.
Thank you all.